Uh, my task is to present for you the recommendations coming out of the Bipartisan Policy Center Rural Health Task Force in our report titled Confronting Rural America's Healthcare Crisis. To start by acknowledging the support of the Leona M. and Harry B. Helmsley Charitable Trust that provided generous financial support for the work of the task force, and members of the Honorary Congressional Task Force on Rural Health that provided their insight, particularly as we got heavily engaged into setting up what we wanted to discuss. And those were the offices and members, Senator Chuck Grassley from Iowa, Tina Smith from Minnesota, Bill Cassidy from Louisiana, and Angus King from Maine, as well as Congressman Jody Harrington and Congresswoman Jyoti Small. The task force was an array of expertise in rural health, people like myself with a grounding in rural health policy over the years, people from healthcare systems like Karen Murphy, who is moderating this panel, clinical expertise from people like Jennifer McKay, a physician with Avera Health System in South Dakota, and then leadership of a lot of policy people really steeped in policy expertise, including our co-chairs, former Senators Tom Daschle and Bill Frist. We had two other senators, former Senators Snow and Conrad, members of Congress, Member Bonilla, as well as Tom Talkie from Iowa. So that's who we formed the task force with that group. A lot of support from very highly capable staff. And then our process for both learning and developing the report included roundtables with stakeholders that made presentations with us and had conversations, experts beyond those that were already on the task force, a series of site visits, and a lot of work with congressional staff, particularly staff from the offices that I mentioned earlier. What I want to do with this presentation is cluster our recommendations with the topic of this roundtable and what is essential to get healthcare providers fully engaged in participating in population health. You've just heard an example of one hospital that's been participating. Yesterday, you heard from Jan Probst about the importance of infrastructure and setting that up appropriately in rural. A lot of the recommendations of our task force are dealing with the stability and long-term sustainability of the delivery system in rural America. And you need to start with that if you want to engage a lot of those providers then in population health. Part of that stability is looking at the short-term situation for hospitals. So we had a series of recommendations here. One of those is sequestration relief. And that's already in place, but only in place right now for the duration of the pandemic. Our task force recommended extending that through the year 2023, increasing critical access hospital payment by 3%, reestablishing critical access hospital necessary provider designation. This was a process that was in place in the early years of that program that you heard described by Paul Moore yesterday, that states were able to designate CAHs as necessary providers, even if they fell within a 35-mile radius or other federally designated criteria, and to make designation of Medicare-dependent hospitals permanent, as well as the adjustment that's in place now for low-volume rural hospitals. Other provisions that are related to the financial stability of providers in rural areas beyond just hospitals include payment for rural clinicians to report data under the Quality Payment Program, or QPP, extending bonus payments for new advanced alternative model participants, and leveraging payment engagement incentives to decrease rural bypass and incentivize local care utilization. Long-term stability, those were all short-term measures. For long-term stability, we had a series of recommendations, again, that would help with financial stability. One of those, grants and loans for capital infrastructure and maintaining service lines or improving structure in patient safety. And capital infrastructure could include converting facilities out of a classic inpatient model into other alternatives. Payment for rural health clinics and expand access to advanced practice clinician services in rural health clinics. There are still some Medicare related regulations in place that are something of an inhibitor. They need to be removed. Increase Medicare capped reimbursement rate for physician owned rural health clinics. In the rural health clinic program, there are two reimbursement rates, and the one for physician owned is lower than the one for hospital owned. We think the one for physician-owned needs to be increased. And excluding enrolled accountable care organization beneficiaries when determining regional benchmarks. So ACOs like the one Tim participates in are judged in terms of shared savings based on a benchmark of previous experience. What we're suggesting is, because in rural areas, many of the rural beneficiaries in that area are ACO attributed lives, that they not be counted, because you're driving down expenditures for them, and that will affect the ability for shared savings in subsequent years. In addition to those kinds of stability moves is being more flexible in how resources can be used. And that's first clarifying rules around co-location of shared space arrangements to allow rural hospitals to more effectively partner with other healthcare organizations. You heard about that in North Dakota and South Dakota in previous presentations. Allow advanced practice clinicians to work up to their state scope of practice in rural health clinics. Exempting rural Medicare beneficiaries from the prohibition against same-day services. So this would allow payment to be made for two different services that occur in the same day, rather than limiting the provider to just one of those services for their payment. And then removing regulatory and legislative barriers that prevent non-physician practices from practicing at the top of their license. There's a lot of progress made in that one in some of the steps during the pandemic. Again, those need to be extended beyond the time of the pandemic. We also talked about incentives and flexibility that comes with incentives. One of those recommendations is to establish a process for rural facilities and communities that can develop a hospital transformation plan. We really put a lot of emphasis around the idea of thinking about what a hospital could become over time in a rural area to more appropriately reflect service needs in that area. We also talked about new models, and we suggested 3 alternative new models to move toward. One of those is actually present in legislation co-sponsored by Senator Grassley from my state, and that's a rural and emergency outpatient hospital designation, and with cost-based reimbursement along with that. So you don't have to have inpatient facility anymore to get cost-based. If that's not really what your community needs, you can move to rural and emergency only. Extending the rural services program, and then working on global budget models like the one currently being demonstrated in Pennsylvania and the one that's in its second generation now in Maryland, shifting from just hospital to total cost of payment. And decreasing qualifying participation thresholds for rural providers in some of the alternative payment models. And this speaks to, again, something Jan talked about yesterday, and the way we bias a lot of participation in those programs toward large numbers. We need to find ways developing the alternative payment models for smaller numbers that we have in rural places. Infrastructure support is another longer term set of recommendations. So prioritize connecting rural areas with broadband, something again that's been heavily prescribed during the pandemic, and there are pieces of legislation, I'm just reading some today in Energy and Commerce, to extend those provisions we have now and add to that. ensuring effective implementation of two of the pieces of legislation that have passed, and the use of telehealth services supported by changes in such things as payment policies, who's eligible as providers, where the sites of service can be, and all those were included in COVID-19 related legislation and regulatory change, but they all have expirations, starting with the expiration of the public health emergency in July, if that's not extended. So we need to be focused on learning from what we're currently doing in that arena and then extending what works. There were a set of additional recommendations in the report beyond those I just summarized that are directly related to population health. The next couple of slides are just summaries of what those are. The further information slide at the end will give you the URL to go and see all of the recommendations. They focused on areas like rural specific CMMI demonstrations, reduction in administrative burden, improving access to quality maternal care in rural areas, utilization of currently available workforce, strengthening HRSA's administration rural workforce programs, expanding federal workforce recruitment and retention initiatives, authorizing licensed clinicians to provide interstate services. That's another one that's in place now, but only through the time frame of the COVID pandemic. And direct the Office of the National Coordinator for HIT to prioritize rural-specific training for the HIT workforce. I want to close my comments with this slide on what I see as necessary conditions to address population health. You need a financially secure delivery system with predictable financial resources, so that the commitments can be made that you heard Tim talk about, short-term and long-term population health initiatives. Payment systems that support engaging and community-driven population health programming. Some flexibility for how the system is built. Those were the recommendations we had from the task force around hospitals and transition plans, transformation plans. Flexibility in how patients, and I would prefer to say persons, interact with a whole range of providers, and there have been several presentations in this roundtable related to that. Our recommendations are really building blocks to move toward population health. A slide with more information, the task force report URL. There's a broader health portfolio. You'll hear more about that during this session. And for more thoughts about the future and transformation, I recommend the panel that I chair for the Rural Policy Research Institute, the health panel. And then finally, contact information about myself. With that, I will stop and turn this over to Ben.